Cannot go beyond down there. That is the most important. Okay. These some cases are from my end, from John and Lynn as well. So this is a patient who reported. If you look at her, from what we are seeing, I will just tell you the history. She has got asthma 10 years. She's removed her wisdom tooth 4A. And apart from that, her primary concern, read the chief complaint. What you have to look in whatever thing that you see, what does the patient come for first? So what a complaint is here? Yes. Now, I look at her. John, can you just let us tell me one comment. By looking at her, first thing, what you will think?
Yeah, so one is yes, an aesthetics is an issue.
The first thing will appeal to you. Aesthetics is an issue.
Definitely aesthetics.
Aesthetics. What will complain appeal to you, Shankar, first?
With the mandible appears a bit protruding.
Okay. So here or there he says aesthetic, mandible protruding. Is something else which is striking to you? Deviation. Very good. And the child, the mandible is deviated. Anything else is more than that?
So maybe a TMJ issue.
Oh, yeah. By looking at somebody TMJ issue, when I come, you're a magician. Something more. So don't say same thing. I can see something more. I saw that only first in this lady. Big guys,
She has a lot of
asymmetry you are seeing. Okay, eye is big, that's what I said. Quick. Asymmetry. Yes, I got.
yeah, she has a lot of family worries.
Family worries, I have not spoken to her. Anything else? You think the maxilla is deficient? No. Yeah, okay. Now see what he said. Now what he said. See, this is what I. See what did he say now?
From the frontal view, we can't see much.
So we have limitations in the view. You get what I'm saying? In one view, we are not getting the third dimension. Remember, frontal, worm's view, bird's view, all views, whatever you can imagine, have to be there for a clinical assessment of this girl. Now, what is this lines that are drawn there? The blue lines indicate what? The red line is indicating what? Huh? Hey, I'm putting a mic to her, let her answer. Huh? Don't push the mic, it's for you. Midline. Somebody said there's a midline, what is that midline? Asymmetry. Is there an asymmetry? Yes, sir. No, midline is straight. I do the line correctly straight. Now, what is this yellow line saying here? I'm not able to reach that side. Yellow line.
Smiling.
What is yellow line? Yellow line.
Conclusion.
No. Yellow line. Why is that between two blue lines one yellow line? End of the upper limb. Why is the lower third divided further? What are we getting? What inference are we getting out of that? Okay, what are the vertical lines? Vertical 5 lines there. Very good. Okay, now John, you wanted this photo. Now you tell me.
So in this you see that there is a maxillary deficiency and also a lower is obviously complicated.
So you agree with maxillary deficiency range?
Sure, sir.
Shankar also agrees.
Yes.
Maxillary deficiency.
And short upper lip also.
Short upper lip also. So that yellow line is indicating lip length. What is the average lip length? Anybody? What? Manga tenga? 18. In school also they do the same thing. 18, 20, what? MM, CM, PM, whatever, something has to be there. So please always, and it should be a range as I told you. So by looking at this picture, you saw the lateral, you saw the frontal, this is the occlusion. Now, Can you tell what are you seeing in the occlusion? So you got brackets, don't tell me that. Now next. Quick, one point. See the teeth. Dental midline is deviated. See, my point is here. Now, having listened for 3 hours or what and everything, something you should tell all of this child. Tell.
H2L5.
Excellent. You have an H2L5. Which tooth is touching first? Is it H2L or the reverse bite in one tooth? Where which tooth? So why did the mandible grow forward? Just because of that, possibly. Possible.
Yes.
Yes, and it is. So supposing somebody is in a reverse bite, remember, there's a constant pressure. There's a constant pressure exerted. The mandible, the growth is affected of the maxilla. This is where early intervention, seeing this kid at 11 or 12, would have prevented this. I believe. So very, very early, 2 teeth are enough to prevent the growth of the maxilla. Just 2 teeth. What will happen? She would end up with a predominantly compromised situation of the lower angle. Now, this lady is strapped up, and see the midline, how much is deviation is there? There's a lot of deviation. But you look at the facial midline, it looks good. Correct? Now, given this situation, in your opinion, what would you like to do for this girl? Her concern is lower jaws forwardly placed.
Yes. About the molar relations.
18 years old.
Molar relations.
Molar is in class 1, no. Class 3.
Molar class 3, canine class 1. If her concern is mandible, I would go for these. So
Okay. He says, I will push the mandible back. I want you to differ with him, please. That is the idea.
If you look at it from the skeletal aspect of the process, she needs both.
She needs both.
She needs both.
So would you be happy in bringing her maxilla forward and putting the mandible back?
No, sir.
No? What do you want to do?
I have decompensation and BSS.
Decompensation and BSSO. Now decompensation, they only put bracket, further than nothing being done here. So bracketing itself took some time, and then the girl did not come. When we have to follow up with the girl, we have to go to their house, bring them. All these challenges are there. When as people say family problems will be there, worries will be there, they will not pursue orthodontic treatment, they will come back after 6 months. Now, madam, now you tell me, they're saying, one is saying they want to put mandible back. Other is saying, want to do both up and down. Third doctor is saying, I will decompensate and push only mandible. Would you compromise the airway in this girl? How will you assess the airway? Something not answered. You didn't expect the mic coming here. I can walk with it. No, anything tell me. Quick! Any analysis is there to check the airway? McNamara. Which view will you take that? Hey, wait, man, I'm here. Hello. I'm not out of the hall. Step. Which step you want to do?
The lateral sense.
Where you do the McNamara analysis? At which location? Which
Near
part of the
the
airway?
upper ear,
Upper where?
behind the palate and
What is the normal airway?
18.
18 what? mm. Everywhere 18 mm cannot be the answer. Okay, so if you do by chance just the mandible in this girl, there is a risk of compromising airway. Possible. I'm not saying no. Highly possible, right? So you bring the upper jaw forward, put the lower jaw a little backward, possible. We are not proud. But again, chief complaint of patient. So, now, brilliantly what happened, orthodontist put the bracket and all the third molars are kept there. One is impacted, one is there. We went ahead with the impacted tooth only because it was not planned well by both the orthodontist and the surgeon. Because patients sometimes, the compliance is not there for surgery. Why I'm coming to this point? If we don't plan in the first day, in the first session, with the surgeon and the orthodontist, full stop, period. You midway, after 3 months, now I don't think it will move. Now we have to go to surgery. This is where the problems come. So planning has to be on day one. If you're getting a patient who's got a skeletal problem, dental problem, orthodontist will take it. If you're getting a patient with a skeletal problem, the patient should be sitting together with the orthodontist and surgeon. Agree or not?
Sure, sir.
100%, no doubt about it. Do we want John people sitting there the first day planning us digitally?
Definitely.
You want John also? Very difficult. John very busy. No, I'm just asking.
Yeah.
Do you think on the day one, we want to show the patient everything, project on the first day and psych the patient?
No, I think surgeon and consultant should be there, but other things I think you need to get all the digital records.
So it takes time, no? So when do you think, John, at some point in time, we have decided that we are going in for surgery and ortho and all that. When do you think that you will come into the picture?
So once you decided that you want to go for the surgery, then whether we want to do, whether we want to start ortho first, whether we want to do surgery first, are we only doing single job, are we going to do job?
So just to ask you a question for the benefit of all these people who are going to practice soon. Supposing we want to do a surgery first, or is it good to take the scan and show something to the patient? The patient is very eager to know how they will look.
It's got pluses and minuses.
Okay. So pluses and minuses. Sometimes you will avoid it.
Expectations are too high when you show.
Now why I am asking this point is, you can't rely fully on something that you will show and convince the patient. So something has to start. So that start could be whatever way that we are looking at, whether the surgery first, orthodontics first, whether we are going to do a pre-surgical orthodontics to this patient or not. So this is the step. So now tell me at this point, somebody has to tell me, where will you measure the airway? Here, here. This is the airway, right? Which I'm giving you 2 points. A, B, C. Tell me. A. Are you sure? It is too high. Okay, this is the best point to measure. So the airway measurement becomes very, very important whenever we do an outline. Now, if the mandible was retruded, what other test you would do? What other test that I would like to complement if the mandible was retrognathic? Police? Police. Polysomnography. Okay. I thought you want to call the police. You want to do a sleep test. Good. That is another important aspect that you should understand. So I think even you did not cover OSAS. No. Very good. So the other thing that you have to remember is when there is a retruded mandible, retrognathia, you should always keep in mind a sleep study, because you can definitely improve the sleep quality by advancing the mandible. Remember that always, okay? So, we have a girl has an orthodontic maxilla by metrics, and a prognathing mandible of 8 mm by numbers. I'm not showing you all analysis and all, that's a waste of time. So, my point here is the problem list is this: reverse overhead, reverse overbite, mandible shifted towards the right, protruded lower lip. Patient's problem list is forwardly placed jaw, aesthetics. At this stage, what would you want to do? Now we are coming to the situation. Maxilla is normal as per metrics.
Only do the mandibles.
Only do the mandible. Anything adjunct you would like to do for this girl?
Because when we look at it, the maxillas are looking a little bit retrograde. Can we augment it?
Soft tissue or hard tissue?
Soft tissue or
Soft tissue or hard tissue. Would you recommend that, sir?
Sir, some peak implants in the maxilla or something.
Peak implant. Okay, he wants to go.
Yes.
Okay, if you want to go with peak implant, where would you want to put the peak implant in this girl?
Below the zygoma.
Below the zygoma. Shankar?
When you do BSSO, you will get a reach of
Bone. You can use that bone also. Right? Got the point? So we are setting back the mandible. We are setting back the mandible. We have to remove a portion of bone. Yes or no? That bone can be used to augment. The patient actually to us looked like he had a deficient nasomaxillary area. What is that? Nasomaxillary. She had a prominent mala, but she was deficient here on the piriform area. So we decided to do only a sag, a setback, and augment the nasomaxillary, that is the pyriform region augmentation. Of course, there were two plans. We do a setback pyriform or a leaford, which we have ideally done if the patient was properly decompensated. If the patient had properly undergone orthodontics, then that would have been possible. But this patient did not follow orthodontics properly, so we had to compromise. So this is what was done for this patient. Reverse, we plan to take a bone graft from the symphysis, also use the bone which we removed from the BSS, okay? And then a bilateral sag. And so you see this this picture which will show you on either side of the lateral of the nose, mucosa augmentation has been done. And then this was the immediate post-operative occlusion. The dental midline was also corrected. At the end of the day, you want your patient smiling. The patient should be happy with what has been done. So what this tells us is, we should always work on what the patient's complaint is and not suggest all the surgical procedures that we do. That is the first important take home in this patient. What pleases the patient without harming the patient is more important. Yes, we can still find out the nose is very bulky, I can do a rhinoplasty. Somebody says scleral shore is very high, I can still do some oculoplastic procedure to close that a little. She can definitely have a sharp nose, all that is possible. At the end of the day, patient is happy. So we want that to happen, and this was a reasonable occlusion, though there's a slight midline issue, but patient did not realize on all that, and that went on very well. So to summarize, would you, in this kind of cases, would you have done anything different? Considering what the patient wanted, considering what was done?
No, I think that's good enough.
Yeah, good enough for the patient. Do you want to recommend any further procedure if the patient comes? She's 18, 19 now. Think a rhinoplasty will do good to her?
Yes, sure.
Possibly, yes. Rhinoplasty would help her to improve.
Usually good understanding, she comes up.
She comes. A very important point. Now, in this procedure, what complication you expect? Yeah, quick.
So,
Immediately, whatever the patient would have had complication. I just spoke in half an hour before. Paresthesia. Paresthesia of which nerve? What type of nerve injury? What type of whose classification?
Sundar and Sanshri.
What is the other classification? Sundar man? Sundar is over. Sundar acha hai, over. Dusra.
Second.
Second. With neuropraxia, is there any treatment is required?
No, like you have to wait, like
How long you want to wait?
3 to 6 months.
If you cut the nerve, what do you do?
Probably put a conduit or also know that.
You know what is sural nerve?
I don't know.
I don't know. I have not done. If there's sural nerve, you don't want to go to the leg, where will you go? Let them know.
get out of them.
Where is it?
Sir, we can use elastic tubes for
Great auricle, where is it?
get out of it.
No. In the head.
Yes.
Neck.
Sorry.
Huh? Great. Great. Huh? Somewhere in the neck is there. Okay. So if you're doing nerve grafting, nerve conduit is a good one, what you say. If you know that the nerve is stuck, create a path. You don't know how to do nerve and nerve. Sorry, I'm not getting the word. So you will put a suture. There's no harm in putting a couple of sutures if you have to cut ends. Making sure that the nerve is in proximity. Don't leave the nerve long gap. Very easily possible. So you can regenerate faster. What is the rate of regeneration of the nerve? No, all these questions are Viva questions. What I'm asking is, all Viva, what is the regeneration capacity of the nerve? Don't know. I'll put the answer. When you examiner should say that only. Don't say something wrong also. No one.
20 to 240.
What? No, I think regenerate. What is the rate of regeneration? 2 mm of what? This is the problem. 0.1 mm. 0.1 mm. Okay? Very slow. Which part of the nerve is regenerating? What is the cell in the nerve called? Mala. Oh. Schwann cell. Schwann cell. Okay. Neurons. What is neuron? I'm going subjectification now. So the point remains, neuropraxia will come in 6 months to 12 months. Don't promise a date to the patient. Same day, patient will come and ask you, my nerve is. And the worst is lingual nerve. The lingual nerve paresthesia, patient will eat your brains. Especially after bipolar surgery. If it happens, it's not something easy to accept. Okay? So that's about the first case. This is a case from Dr. Ling. Okay. Now I will first take comments from the student and then come to your. Because all three pictures are together. Now, which side I will go in? Here. What is in the face?
Problematic management.
His camouflage, his beard, no? Because somebody told me, whatever surgeon told me, everybody's keeping a beard, you don't know actually the patient has got a jaw problem. All boys have beards. See that why? They have a jaw problem. You shave and see tomorrow? You can, he probably has one.
Prominent bony line.
Prominent gonial line. No. Huh? Nose? The nose is big. Okay. Sorry. You're only seeing the nose. Mandible is prognatic, very.
Shadow mental sulcus.
Shallow mandible is sulcus. Good.
Prognatic mandible.
Prognatic mandible. Don't repeat. Any other findings, special finding you have? Retrognatic maxilla, yes. And question extra. Nothing. Okay. So you get different things that we have got now. We have got prognatic mandible, retrognatic maxilla, shallow mental sulcus, prominent nose, depressed maxillary area. Okay. Sorry? Can you comment on the occlusion? What?
Reverse object is
Reverse object?
anterior
And your other name for it? Other name for it? Academia, good. Why is anterior abdomen of the cause? One cause.
Tongue twisting.
Tongue thrusting. Any other cause? Pressure? Posterior facial height being less. Interesting. Okay, so you have an anterior open bite, retrognatic maxilla, patient is trapped up. What? The next step. Do you think it's a bite job?
Yeah,
Definitely a bite job, right? Would you want to think of doing a simple anterior procedure for these kind of patients? We know the Coles procedure as we talk, because people used to do that in the past. Just to close the open bite. Can be partial.
That's to be.
You want to do in addition, supposing this patient is a tongue thruster.
Yes, sir.
What do you want to do before we do a surgery? Tongue thrusting, one of the causes of AOB.
Yes,
You think we should do something preventive before the surgery, sir?
keep the
Tongue spike. So you would recommend that? Ideally.
Yes,
You recommend?
ideally, yes.
I strongly believe in it.
Yes.
Because otherwise post-surgery, if the patient keeps on doing. Do you do any, supposing you have AOP and tongue thrusting, do you do any tongue reduction procedure in orthodontic?
So, well, my boss always used to say this tongue thrusting and this open bite is like a chicken and egg problem.
Which came first?
Which came first? He always used to say that. So in a way,
Because of the space that comes
space, that's what he said. So we have never done production of tongue size, but there are some cases which you definitely think that maybe the size is too big.
Do you know of any tongue reduction procedure? We don't cut off the tongue. When I say tongue reduction, we reduce. Glossectomy. Brain. Glossectomy is not for ordinary. How many? There are 4 types of tongue reductions. Any of you know? Please go through literature. There are 4 ways you can reduce the size of the tongue. And this is to be done in cases of tongue being large, particularly when anterior open bites or where there's a constricted jaw and the tongue is big, or there's a case of a lot of spacing in the teeth. Because of constant tongue thrusting, the spacing has happened. So sometimes you need to do adjunctive soft tissue procedures, and one such procedure is tongue reduction surgery. Okay, what kind of extraction would you do in this if it's a bijaw? Now to me it looks like, I'm just thinking, it's a bijaw, you probably have to do a LIFO one and as a mandible procedure. In that case, in orthodontics, what do you do?
Yeah, so for us, mandibles is going to be a mandible procedure also, sir.
Yeah.
Remove of the premolar
Ah.
to premolar.
So ideally in orthodontics, when we do decompensation, the extraction is upper 4, lower 5. Is this standard protocol, do you agree or not?
In this upper, I will not.
You don't want to do upper in this patient.
We try to bring the max.
Okay, since it's coming forward. Okay.
No, sir.
You don't want to do any extraction in this patient. Okay. You're happy to just do yours. Because there is no gross,
Bypass surgery, max.
but no extraction. Non-extraction. You also okay with non-extraction?
I like to play around with the cast.
Yeah, cast. Self. Okay, this is the OPG. I think it was planned for bijaw, so the third molar has been removed. Correct, no? I can see the shadow there. Nice. So that has to be done. So which means you should see good bone and then only go to the mandible. Not like Vasant was saying, and 2 weeks before you do surgery that you did, you said. Yeah. Somebody going abroad, you remove the tooth, 2 months, 2 weeks later you go and do a surgery. 100% that's split. Best is to keep the tooth there and go split it. That's a much safer bet than doing a third molar 2 weeks before your sagittal split. It will be worse. Never do that. The self is there early. Okay. Problem list is maxillary retrognathism with dental proclination, mid-face, mandibular prognathism, skeletal class 3. Okay. So treatment plan was a maxillary advancement and a mandibular step back, straightforward. Okay, now comes my job. What are the different types of Leaford 1 osteotomy? Don't see books. He's taking notes. Quick, man. Say 2 modifications of Leaford 1. Where do you put the incision? Extent of incision. Oh, sorry.
What the first one is?
First molar. Who will come in between whom you don't want? Who will come in between in the molar whom you don't want? The freedom will come. Buccal fat pad will come. Buccal fat pad, where is it? Why should it come? I'm sorry, supraperiosteal if you go. Okay, once you make the incision, what do you do next step in Leaford 1?
Osteotomy.
Okay, and where, what do you do first step? I want to do osteotomy only. Huh? Reflection of that. Over, back, over. Next step, quick. Step in osteotomy.
Protection of the neck.
Protection of nasal floor. Very good. Next. That one is osteotomy first result. I don't want to. Everybody wants to do nose. What do you do first? Mucosa. You want to understand mucosa? Marking of the posterior. Covering the posterior. Going, reaching the derivative tension. Lateral wall osteotomy first. Yeah, the nasal. Oh, he was nasal. The nose will disappear by now. Why he was reflecting nasal itself? No, you don't want to do anything. Stop osteotomy. Stand up over. Next step, nobody starting. the septal, what problems will you encounter? Septal. Is there also measure? Which is it's called, numbers are written there? Yeah. So it's a curved instrument, two ball at the end. Yeah. Why that ball is there? Guarded. What is the depth? If you are not doing pterygoid disjunction, what will you do? What's the alternative? Huh? Trembl's modification. What is Trembl's modification? Huh? Going through the socket of the third molar. Why do you want to go through the socket of the third molar? Because you don't know how to do pterygoid disjunction. Correct?
No, sir, it's like if the maxilla has anteroposteriorly.
No. When you decide to go through third molar, when you don't do it, both have a criteria. It's not preference. What is the direction of the instrument when you put a pterygoid chisel? No. You put it in the separation of the maxilla and the pterygoid plate. What is the direction of your osteoconsective? Downward and? If you go superiorly, what will happen? Where are you going if you go superiorly? Which bone? Which bone? Which bone? Which bone? Superiorly if it goes, which bone are we going in direction? Sphenoid bone. What is the foramen there? What is the structure behind the pterygoid plate going inside? One very important structure. Important structure behind the pterygoid plate close to that groove. On both the sides it will enter. One big fellow. Remember, there is something called internal cavity. Extremely dangerous. Extremely dangerous. Okay? So be aware of that. Now, just to highlight them, tremulous modification and pterygoid discharge. Is there any specific criteria?
Okay, tremble modification is usually done only when you have need a setback. Setback. That is the problem with the pterygoid dissection is always fractures going upwards into the orbit. So tremble modification, the advantage is that you are
This point is clear that I give you pictorially. Tuberosity maxilla end is here. The pterygoid plate is jutting like this. Got it? So if you want to disjunct it here, to push it back there is resistance. Your pterygoid plate is attached to sphenoid. You will crush it little, you can't remove it fully. You go behind that to remove bone to push it back, you are in disaster area. Deadly dangerous area. So,
You get this
his point is, if I remove the tooth here, this much space I am getting to play. Got it? Clear? Oh, both of you don't fight there. Telling you some important point there.
what will happen if you advance with the tremble modification?
That's also a very good question. You make a tremble and you advance. What can happen posteriorly? Huh? How come it come on? No, see, now I told you a situation. I have removed the tooth, so much space I have created, I am pushing it back. But so much space is there, in spite of that I am bringing it forward. So what am I creating? I am creating a big gap there. There is no bone-to-bone contact at all. So there can be a problem. There could be a problem. There is no union. There could be a failure. The segment is not stable. There should be bone-to-bone contact somewhere. Correct? Next. You're not. Okay. So this is the post-operative of this guy. He has undergone a byjaw procedure. Now we discussed a little bit about the SAG. I'll just ask you 2-3 questions on the D41 complication. What is the immediate complication in D41 also? Airway. Nothing. No complication. Very good, sir. Yes, sir. Very complications there. Huh?
Temperature.
Which vessel will it need? Which? Why ascending body and any other blood vessel can be?
Temperature plexus or
Plexus convert, yes, posterior breathing technically, nuisance if there is there.
Internal
You don't want to see it now. In life, I don't want to see it now. No problem. Okay. So apart from bleeding, any other complication post-operative before? Huh? Neurosensitivity. Yes, please. Good. So that would be a posterior contact, premature contact, not fixed.
avascular necrosis.
Oh, that will come late. 6 months later. Don't see it. Don't wish for it.
opening of the wounds.
Gaping of one very simple thing. See, 7 days later you find the plate is exposed.
Nasal deviations.
Very good, septal deviation.
Sir, open wide, sir.
Thank you, man. You listened to me a little bit while I was talking earlier. I'm very happy. Clap for yourself. Huh? Clap, clap, clap. Thank you. So then, when you complete what you did, what technique? Is there any specific technique you followed? When you sat, what modification you followed?
So it's a normal one.
No, just tell the students here.
So first, we do a mandible cut, BSSO cut, and you don't downfrag. I mean, mandible is done first, but won't split the mandible, just do the cuts of the mandible. After that, we go to the maxilla. We do the downfrags of the maxilla, do advancement of the maxilla, intermediate split is placed, fix the maxilla, then we do the mandible, split the mandible and do a setback. And with the original split, first the intermediate split, next the final split. So it is first do a mandible cut I do, then go to the maxilla.
The reason why he's saying that you're doing the mandible cut, when you are fresh, that is what many surgeons believe. That the surgical cut, though it seems very simple, yes, it is simple. But when you've done more and more surgical splits, you realize it's sometimes easier than the thermal or removal at times. Okay, you do the osteotomy, but don't break the mandible. Do the full osteotomy, complete it. That it should be ready to be spread. That level you pack pause and go to maxilla. That's what he's coming to say. The advantage being that sash, that feel is not there because it's the depth you're working. You need a lot of concentration in doing the sash. Whereas maxilla is more in the front. Vision is good. Here the vision is at the back. In fact, apart from the surgeon, nobody can. In fact, surgeon also, most of them can't see what he's doing. That's the truth. We are just going by feel of when we do a sash. You understood? And then you go ahead with the maxillary osteotomy, and then complete, fix the maxilla, and then break the mandible. This is the post-operative. Genioplasty was also done for this body. Okay, here is a patient. What can you see in this guy's face now? First thing striking. Like vertical maxillary access, very good. But what is a striking thing that I see in his face? I see only teeth, correct? The first thing that is striking forward is the teeth. So he's not able to close his mouth. He has got all his teeth visible in the maxilla. Yes or no? Why did he come? Only concern. Forward he placed, upper teeth. What has happened to him now? All the division, multiplication is all done here. But at the end of the day, we are looking at slightly lower third is slightly deficient, yeah, compared to the other thirds. Am I right? You agree with me? So, okay, lower third is slightly less. His concern was, he looks not good, people are not accepting him in the society, and not getting married obviously. 3 concerns he had. So our concern has to focus towards that. Now what do we see intraorally? What has happened to his lower teeth? We see deep bite. So what is exaggerated in this patient? When there is a deep bite, what happened to the curve of speed? How is the normal curve of speed? What direction?
So it goes from the cusp tip of the canine and it
Posteriorly it has to go up. Here, from the back, it is coming like this. It's like a pyramid here, like a cone in the front. You understand? So its entire lower teeth is completely gone inside the maxilla. The severe maxillary excess. What in this situation, Dr. John, what do you do ideally? Let's forget his concern. He comes here, we need to do something good for him. What would you look at first in this game?
Orthodontics first.
Orthodontics. You would prefer. Because we can't do a surgery first, very difficult with us. You agree with that, no? It's very difficult to handle this patient. Bite is the challenge here. So orthodontics means what will you do now?
Sir, orthodontic,
Severe retroorthic mandible.
we have to look on that at the bite.
Yeah.
So, bite has to be
It will
raised.
take ages, but to get that bite corrected. Yeah, because basically the lower anterior should intrude. So that intrusion comes only as level of curve of speed is going to get corrected.
Yes.
So orthodontics is compulsory.
Yes, sir.
With extraction, obviously, at least in maxilla we'll have to extract. Because the maxilla, otherwise it won't go back. You agree?
Maxilla, for me, vertical maxillary exists.
Yeah, vertical maxilla. Okay, this is how his posterior look. See where his lower teeth is, it's at the side, it's almost at the gingiva, parietal gingiva completely. This is his OPG and teeth that you're looking at. Ceph. Now you look at the ceph and tell me what you want.
For me, it will be a default one in anterior maxillary osteotomy, so that the
Yeah, it's a combination.
combination.
So that means you'll do the extraction on the table?
Yeah.
Okay. So listen to this point. Says we do orthodontics, we do alignment, basically to correct the bite, but we do a two-piece in the maxilla, which means maxillary leaf-out combined with antemaxillary osteotomy. The force will be extracted on the table. So we don't waste that orthodontic time of closing the space. We close the space in 5 minutes. Don't take your orthodontics.
And the mandible also needs to advance. Genioplasty, obviously, but
The mandible has to
there
advance.
is
So,
no
yeah.
over suction over here.
So we will do that space of the fold, we will push it back, we will take the maxilla up, that is what ideal, and then we advance the mandible, plus minus genioplasty have to be worked out for them. John, in digital planning, just asking a question now. With this kind of a patient, what kind of a plan that we can work out? Suppose you want to really do good to him, at this stage, what can you do?
So same sequence of whatever we sensors. I mean, do the whole default or do an AMO impact, because like this itself, they can't push the mandible forward because it's
Impossible, they can't move, you can't do it.
So that digitally we will straight away see it. So impact the anterior portion superiorly impacted. That will give us a space if we want. Bring the mandible forward. Once we bring the boning tissue forward, then we know how much of soft tissue chin is, and then how much of genioplasty we need to do, we can already plan it. So that sequence we can run.
Counterclockwise, yeah. Anything differently you would like to contribute in?
No, sir, same. Leave out the MO and 3D plus.
This is what would be ideal for this person.
I think when the anterior part, you bring more on the anterior part, vertical correction.
This
Yeah. Instead of doing, push that, and it's like a more definite.
Okay, so now this boy was not willing to wait for too long. And orthodontics and everything we said would take about 1.25 year for us to correct the level of speed, to align the level, to align some teeth, and then do bite or surgery. About 2.5 years roughly he would have had to wait to go through the process, but did not have the patience. So this are the concerns for the patient. I mean, what we found: overjet, overbite, midline shift, lip incompetency. Basically, a forwardly placed jaw and aesthetic was his concern. Ideally, it would have been this before one osteotomy and a BSSO. This would have been the ideal plan for him, plus minus genioplasty. But then we were left with a small compromise. We had to do something alternatively. Now, what is the procedure that you're seeing in the first picture? What is being done in that procedure? First one, lower, top left. No, it's not genial. I have genial. You see something there? Subapical osteotomy. Yeah? When you do subapical osteotomy, what you are supposed to do? Extraction of fold. Now, this patient, we decided not to extract because already this mandible is retrognathic. You extract, we further push the anterior fragment back, and then we spoil whatever occlusion he is going to have. So we have done now what is called a intrusion subapical with no extraction. So only an osteotomy has been done between the canine and premolar and removed almost 10 mm of bone. For what? For what? That anterior teeth to go down. So we corrected the curve of speech surgically. Thereby we created space in the maxilla. So this went down, segment went down, got fixed. A typical anterior maxillary osteotomy was done. Upper folds were extracted on the table. And you see the last picture, the mandible got aligned with the curve of speech getting corrected. Got it? So these are all modifications to what we do. Routinely we don't have to extract. So you can intrude because the bone height was so much. So you wanted your curve of speed to get corrected. That is why corrected surgically without orthodontic. Corrected, AMO done. Patient not too great, but because that went down the chin, you look at the chin, it looks a little prominent. Maybe we could have combined a genioplasty on this guy, but I didn't risk it because the limb of bone that was available was very thin at that time. Maybe you could have done better if I could have done an augmentation genioplasty. What is an augmentation genioplasty?
Bone graft.
Bone graft, good. So if I planned a bone graft, we would have succeeded very well. Then it would have been picture perfect for this guy, for his demand that he had. But this also, he was extremely happy. Why? His teeth were not shown in his mouth, in this case. Simple. Right? So his goal was, his teeth should not be seen. We did not disturb. What is the advantage of doing a segmental osteotomy in the anterior? You do not disturb the posterior occlusion. Posterior occlusion remains the same, but not in all cases. In compromised cases, where patient wants quick result, don't touch the posterior. You will make a mess for your life. Keep this as it is. That is why we call this those days marriage osteotomies. That was common. We used to call it operation because maximum when we were postgraduates, my boss used to say, "How's the occlusion? Do air most of it. Air most of it. Fast work. 3 hours we are changing the appearance. 3 hours. Patient is changed. 2 months later they get married. Next year child comes along for review. You understand the difference? So we used to call it marriage osteotomy. And this guy, is he married, right? No? Yes, sir. Huh? Engaged. He got engaged now. So what it does is the level of confidence. This is what we have to do. So simple things are still good, but the concept of segmental osteotomies are dying down. Agree or not?
It's difficult to know sometimes, segmental osteotomy than before.
Yeah, see now, because we all got used to doing full job. Yes. See, the facial appearance, the soft tissue gives an aged look. It gets collapsed. The prominence of the lips does not come. That is where we don't do segmental as a first choice today. Remember that. Result will be rewarding. But you give that guy a very oldish look. Maybe even look aged a little earlier than what he should be. But patient-wise, he is extremely happy. And this is the post-op, right? Now his lower teeth is all visible. Beautifully visible. Because earlier what was not seen is now visible. And his occlusion is good at the back also. Okay, the last case, even another 5 minutes we are done. Yeah, I told you, 5 minutes. Oh, 5 minutes, 5 minutes. Oh, thanks. I think John could comment on this straight away. This purpose of these pictures are, don't take any photographs, sir, please. It is for you to understand where digital planning has absolute role. Absolute role. With this to be, if it comes to me directly, it may be very difficult to plan. Yes?
Yeah, so this is a
This is a
patient.
report of the patient answered.
So this is the patient who came. The case was sent to us basically to plan for facial asymmetry. Young girl, okay, her complaint was asymmetry, she's not able to close her mouth fully, and she's been like this for from child. And I think there was also some form of a procedure done for a year, which they didn't give us that report. Now, our objective is she wants to smile, and these are the kind of